So welcome everyone who decided to join us today. So it's my great pleasure to open our webinar series of the European Diabetic Nephropathy Study Group. EDNSG is a community of dedicated clinicians and researchers focusing on diabetic kidney disease. My name is Pierre-Jean. I'm a clinician. I'm professor of therapeutics based in the Clinical Investigation Center in Poitiers, France, and I'm a member of the EDNSG Webinar Committee and your host today. I'm really pleased to introduce Professor Peter Bjornstad as our opening speaker. Peter is Professor of Pediatrics and Medicine. He's also Director of the University of Washington Medicine Diabetes Institute in Seattle. He has received multiple honors from the American Diabetes Association as well from the Breakthrough Type 1 Diabetes, formerly JDRF. His research has focused on kidney disease, cardiovascular complication in youth and adults with diabetes. And today, Peter Bjornstad will talk to us about diabetes, kidney, obesity, and bariatric surgery. So welcome, Peter.
Thank you for the kind introduction. I'm grateful to take part of this EDNSG webinar, and I've entitled my talk, Cutting Weight, Saving Kidneys, Metabolic Bariatric Surgery in Youth with Type 2 Diabetes. These are my presenter disclosures. So I've divided this talk into two parts. So for the first part, we'll talk about the burden of diabetic kidney disease in youth onset type 2, and then we'll make some comparisons against adult onset type 2 to really contextualize the high burden and severity of this complication in youth with type 2. And then for the second part of this talk, we will discuss the effects of metabolic bariatric surgery or weight loss surgery on early kidney disease in youth with severe obesity with or without type 2 diabetes. So starting with the high burden of kidney disease in youth onset type 2, here I share some data from the Today 2 study, which was a large multi-center NIH-funded study across the US. And the data shown here were published in New England Journal of Medicine in 2021. And what we show here is that youth with type 2 diabetes, when they entered the study, they were only an average of 14 years old. And despite that, over 15 years, the cumulative incidence of developing early diabetic kidney disease was 55%, which is substantially higher than what's been reported in adult onset type 2 diabetes when you consider diabetes duration. And I may not have convinced you yet, because we all know that albuminuria does not necessarily imply progressive nephropathy and may in fact regress to normal albuminuria. And for that reason, we wanted to look under the microscope and leverage kidney biopsies. So looking here at kidney biopsies from American Indians with type 2 diabetes, and this cohort of 161 participants were stratified whether they were youth onset or adult onset type 2. And what we saw under the microscope is that youth onset type 2 had greater glomerular basement membrane width, greater mesangial fractional volume, lower surface density, and also lower podocyte number density per glomerulus. Taken together, these data suggest more severe structural parameters in youth onset type 2 versus adult onset type 2. So to summarize part 1, the high burden of diabetic kidney disease in youth with type 2 diabetes and severe obesity. So we reviewed data indicating that youth with type 2 face an alarmingly high burden of kidney disease, especially when compared to adult onset type 2, which includes higher rates of albuminuria and more severe kidney structural lesions. And this really calls for early and aggressive interventions to prevent this devastating long-term complication as these young individuals are transitioning to young adulthood, which is supposed to be the most productive time of their lives. So for part 2, we will discuss one of these interventions, that hold promise, and that is weight loss surgery or metabolic bariatric surgery. To better understand the effects of metabolic bariatric surgery, we're going to leverage Teen Labs. And Teen Labs is also an NIH-funded multi-center study in the US that followed youth with severe obesity, with and without type 2 diabetes, before and many years after weight loss surgery. And what I show here is fairly fresh data from last year. This was led by Justin Ryder out of Lurie Children's, where they looked at the outcome data of up to 8-year follow-up, sorry, up to 10-year follow-up. And what they found, as you can see to the left, is that changes in BMI from baseline in these youth and teen labs was the same whether they underwent sleeve gastrectomy or vertical sleeve gastrectomy, or perhaps the more traditional gastric bypass. What they also showed in the panel to the right is that remission of type 2 diabetes, hypertension, and dyslipidemia was really impressive. In fact, the 10 years after weight loss surgery, the percentage of remission for type 2 was 55%. And that may not seem super impressive, but when you compare it to what we see in adults, meaning those that undergo surgery as adults, it's between 18 to 12% remission rates after 7 to 12 years. So it's substantially higher in those who undergo surgery as an adolescent. Well, what about kidney disease? What are the effects on kidney disease? So this is a busy slide, and I'll walk through it. But on the y-axis to the left, we show estimated GFR by creatinine and cystatin C. On the x-axis, we show visits or time in years. And then on the y-axis on the right, we show geometric mean of albumin-creatinine ratio. And then there's 3 colors here. So at the top, we show blue, which is the prevalence, which is the rate of hyperfiltration. Then we show low eGFR, and then we show albuminuria at the bottom in red. So focusing on hyperfiltration, which we defined as an eGFR equal or greater than 135, you can see that 24 individuals met this definition at baseline. This would be equivalent to 9%. And then in terms of the baseline mean eGFR, it was 153, and at 8 years, it decreased to 135. This mounted to an attenuation of hyperfiltration by a mean change in eGFR of around 19 mil per minute per 1.73 square meters, and this was very statistically significant. Well, what about low eGFR? So low eGFR in youth is typically defined as less than 90 mil per minute per 1.73 square meters. And again, here, we found that the baseline prevalence for impaired GFR or low eGFR was seen in 42 individuals with a prevalence of 15%. The baseline eGFR was 75 on average, and it improved to 96 after 8 years. And this mounted to an increase or an improvement of around 21 mil per minute per 1.73 square meters. And again, this was statistically significant. What about albuminuria? So albuminuria, defined as equal to or greater than 30 milligrams per gram, was seen in 10% of individuals at baseline, or 28 individuals. Their baseline geometric mean albuminuria was 117, and it decreased to 15 at 8-year follow-up, and the geometric mean ratio here was 8, and again, very statistically significant. So reviewing these data collectively suggests that if you have hyperfiltration, there's attenuation. If you have impaired or low eGFR, there is improvement. And if you have albuminuria, there's attenuation. And these effects are quite impressive because we're looking 8 years out from surgery, when a lot of individuals would also have regained some weight. So what are the mechanism of kidney protection? So this is still poorly understood. So to try to address this and uncover the mechanisms, we performed a mechanistic observational study called IMPROVE Type 2D. What was unique with IMPROVE is shown here in the slide, in that we had research kidney biopsies before and 12 months after weight loss surgery. And that has allowed us to look under a microscope at these kidney biopsies and also perform state-of-the-art molecular analysis of this tissue to better define mechanisms of protection afforded by metabolic bariatric surgery. So who were these individuals? So IMPROVE was larger than the individuals that had kidney biopsies, which was only performed in a subset of the participants. So in total, they had an average age of 17, an average A1C of 7.5. They had a high BMI, as you'd expect, because they qualified for bariatric surgery, of 41. 40% of them had elevated albuminuria. It's also worth noting that all of them, after metabolic bariatric surgery, which in this case was vertical sleeve gastrectomy, experienced normalization of their A1C, the ability to stop all diabetes medications, and normalization of their albuminuria. When we looked under the microscope for the subset that had paired kidney biopsy, meaning before and after weight loss surgery, we saw some important observations. If you focus to the left, this is based on kidney MRI first, and what we saw there is that the total kidney volume substantially decreased from baseline versus follow-up. So these very large kidneys, pre-surgery, normalized or decreased 12 months after surgery. When we looked under the microscope of the kidney tissue, as shown in the table to the right, you can see that it wasn't only the whole kidney that decreased in size. We also saw a decrease in glomerular volume, mesangial expansion, as well as glomerular nuclear count. So we saw an attenuation of hypertrophy both on the large scale of the whole kidney and also looking at a small piece of tissue under the microscope. What about the molecular analysis? So we performed single-cell RNA sequencing. To the far left, you'll see a UMAP. For those of you not familiar with the UMAP, each dot here represents a cell that have been clustered based on their cell type membership. And then in the middle, you see a UMAP with two groups. And one group is the samples from before surgery, and one group is the samples from after surgery. And you can see there's a nice overlap, and that is a quality control assessment to make sure the distribution is fairly balanced so we can make meaningful analysis. And then to the far right, you see the number of cells represented in each cell type. Not surprisingly, we see more cells in PT, or proximal tubule, and tau. In total, we had around 24,000 cells from the 5 pairs, meaning the 5 individuals with biopsies both pre and post surgery. Here we show the number of suppressed and enhanced transcripts, and these are the differences between before and after surgery. And you can see we saw the highest number of enriched or changed transcripts in the proximal tubule, the tau, followed by PC, meaning pericytes and endothelial cells, or ECs. We're really focusing on the 2 top cell types, meaning proximal tubule and thick ascending limb, or tau. So we looked at these 2 in particular, which you'll see in the volcano plots to the right. And you can see we found significant number of transcripts that both went down, which is shown in the red in the volcano plots, or went up, shown in blue in the volcano plots. But due to the sheer number of transcripts going both up and down, we focused on shared changes between PT and tau to suggest shared intrarenal biology. And by doing that, we saw that the overlap in terms of enhanced genes after metabolic bariatric surgery between PT and tau was 222. And a lot of these were related to known players such as AMPK signaling, FOXO signaling, and then we found significant overlap between PT and tau for suppressed genes, actually 863, and they were very much enriched for metabolism, so downregulation of oxidative phosphorylation, glycolysis, Krebs cycle, glutathione metabolism. There are many limitations of traditional gene set enrichment analysis. So to better understand changes in mechanisms, we leveraged a method called progeny, which identifies pathway activation from gene perturbation data, allowing us to capture broader and more interconnected signals, changes beyond traditional gene expression. And leveraging progeny, we were able to show that JAK-STAT, EGFR, and P53 were significantly decreased in response to metabolic bariatric surgery. Also, mTOR activity, which is a key regulator of metabolism, was found to be decreased after weight loss surgery on immunohistochemistry. Here we show immunofluorescence staining of ribosomal phosphorylated S6. And you can see that the intensity is decreased in the post-metabolic bariatric surgery samples, indicating decreased mTOR1 activity. Bringing all of these data together, we suggest that lower insulin concentrations, insulin sensitivity, leads to less activation of two major, including RAS to ERK and PI3K to ACT. And both of these pathways attenuate mTOR. By attenuating mTOR, we have downstream effects on decreasing cell growth and proliferation, probably explaining why we saw that decrease in total kidney volume. And there's also important impacts on autophagy and metabolism through AMP kinase and FOXO3 as well. Also, due to decreased inflammatory burden, we also see a decrease in STAT3, also having important downstream effects in terms of kidney health. So to summarize part 2, metabolic bariatric surgery show early promise in attenuating early kidney injury in youth with type 2 diabetes and severe obesity. Integrated molecular analysis highlighted reductions in energy-intensive processes and JAK-STAT and insulin signaling, resulting in mTOR attenuation and providing mechanistic links between metabolic bariatric surgery and kidney recovery, with potential implications for non-surgical therapies. And with that, I would like to acknowledge my team for all their contribution, and I appreciate your attention.
Welcome everyone, and thank you for joining us today. It's my great pleasure to introduce our webinar series of the European Diabetic Nephropathy Study Group. My name is Krishna Adeshra, and I'm a research fellow at Folk Health and Research Center, University of Helsinki, Finland. I'm a member of EDNSG Webinar Committee and your host today. I have a privilege of introducing our next speaker, Dr. Maria José Soler. Dr. Soler received her medicine degree from the University of Barcelona in Spain. She is the head of the Clinical Nephrology and Dialysis Unit at the Hospital University of Vall in Spain. Her research has been focused on clinical and translational aspects to understand the molecular mechanisms driving diabetic kidney disease. Dr. Soler has authored over 200 publications and is Deputy Editor-in-Chief of the Clinical Kidney Journal. Currently, she is the Vice President of the Spanish Society of Nephrology and the Chair of the Western Europe Regional Board of the International Society of Nephrology. Today, Dr. Soler will share her insights on diabetes, kidney disease, and obesity. Please join me in giving a warm welcome to Dr. Maria José Soler. Welcome, Maria.
Hello, my name is Maria José Soler. I'm a nephrologist. I work at the Hospital Vall d'Hebron. I'm the Chief of Nephrology and Dialysis Unit at Hospital Vall d'Hebron, and I'm also the co-research leader of the Vall d'Hebron Research Institute of the Group of Nephrology and Transplant. Here you have my conflicts of interest. I will start by an introduction. Obesity years ago was considered to be fashion. If you were at that time overweight, this was good, and it's supposed to be because people that were not with obesity, they had not the ability to find food or to be in healthy manners. But after years, we realized that the pictures of Botero and being obese, like as you can hear these pictures from Colombia, that is not really good. And the most important thing that I would like to introduce you in this webinar is our new consensus. This is a consensus performed by the Spanish Society of Nephrology, the Latin American Society of Nephrology, and the Spanish Society of Obesity, and is a proposal for a new classification in the obesity-related kidney disease. If this webinar is open before October 8th, I don't know. This consensus is free. I will share to you the link, and it's free until October 8th. And if not, you will find the consensus in Kidney International. In case you are interested, here you have the open access, the QR, the Q for going directly through the link. So what happens with kidney disease in obesity? This is clear from years. Endocrinologists and other specialists, internal primary care specialists and internal medicine that have been studying obesity didn't have forget about the kidney in patients with obesity. Including in the graphs or the publications, they mention the morbidities as high blood pressure, high cholesterol levels, cancers, quality of life, sleep apnea, type 2 diabetes, stroke. But the kidney has been forgotten for years. Where the nephrologists, we already know for years that our patients had some kind of kidney disease related to obesity. So there was not a match between the doctors that were taking care of patients with obesity and nephrologists that already know that some kind of obesity is deleterious for kidney disease. Thanks God that at least 5 years ago, this match started because, and maybe it's because some drugs started to be useful for patients with obesity, because to deal with obesity, there are different types of treatments, but we have now drugs that help to lose a lot of weight. And in that sense, this is a nice image figure from Cleveland Clinic, where you can see that they already started to visualize kidney disease as secondary to obesity. Visualize and realize, because actually this was already a fact. Why obesity has been forgotten or has been not considered as the disease? Both obesity and and chronic kidney disease and kidney disease have been the silent disease for years. What this means, people did not recognize obesity as a disease, and the kidney disease used to be diagnosed late when the patient is almost in the door of dialysis unit. So, as you can see here, the obesity was not recognized because of war and famine, because of cultural reasons. When I was young, my grandma used to say me, if you have a little bit of fat, is better for you. How are you? Eat, please eat, for healthy misunderstandings and for lifestyle changes. The type of food the fast food that is coming now favors obesity. And why the kidney has been a silent disease? Because there is no social alarm. You don't have pain in the kidney until you have a really advanced chronic kidney disease, because it's an unknown disease. Sometimes when I say to the people that I'm a nephrologist, they look at me saying, what's a nephrology? And because for years, there has been paternalistic. When your kidney is not working anymore, we have several things that we can do for the patient. But for years, the patient come to you and say, doctor, what is my best option? What should I do? And you say, you have to go to this track or the other track. And now we have modified that, and the patient decide, because and this is a shared decision with the patient, because actually who is going to do the therapy is the patient and not the doctor. So why to be obese or overweight is important? It's important because is really frequent, as you will see. And what is obesity? Overweight is when you have a body mass index higher than 25, and obesity is when you have a body mass index higher than 30. The prevalence of obesity in the world has tripled, multiplied by 3 since 1975, and currently it is calculated that 650 million of adults in the world have obesity, and 340 million of children. And the problem has reached epidemic proportions, and it's calculated that more than 4 million people died in 2017 from being obese or overweight. And what about obesity and chronic kidney disease in Spain? It's calculated that around 40% of the population in Spain has overweight, and 22% is obese. And what about the patients that are in chronic kidney disease program? The patients with chronic kidney disease, 3 of each 10 patients are obese. This is data from 2018, and now we are performing a study that I will mention later on to know what is the real prevalence now. And what happens if you have chronic kidney disease? If you have chronic kidney disease, the mortality in patients with chronic kidney disease has clearly increased by 30% in Spain. So causing 10,000 deaths in 2016. Who realized or performed this guideline? I think that this new consensus. Who performed this new consensus of classification of obesity and chronic kidney disease? We joined a group of nephrologists, endocrinologists, a multidisciplinary group, and pathologists from 3 societies, and we decided to perform this consensus. And I will tell you why also we decided to do this consensus. We decided to perform this consensus because what is not diagnosed and is not recorded never will be treated. So we have now treatments for delaying the progression of chronic kidney disease. We have treatments now for the obesity. If we do not diagnose our patients of obesity and chronic kidney disease, we will not treat. 3 societies, as I mentioned you previously, la Sociedad Española de Nefrología, Sociedad Española de Obesidad y Sociedad Latinoamericana de Nefrología y Hipertensión Arterial. What do you know until now of obesity and chronic kidney disease? This is a nice study performed by the group Dagati group in 2019 that was performed in 248 patients with morbidly obesity. That is a real important obesity. So, as you can see in this study, they included 248 patients, and they studied that where kidney biopsy was performed. They studied the diagnosis of the kidney biopsy, and they studied which one of the patients has obesity-related glomerulopathy alone, which patients, the percentage of patients that have obesity-related glomerulopathy with other lesion, or other lesion alone. Actually, you have to take into account that in these patients, it was the thinking years ago was that this patient had a risk for bleeding, and you only perform the kidney biopsy in those patients under the suspicion of non-obesity related glomerulopathy in these patients when you have the suspicion of other diseases. You can see here the age of the patients, the middle age, as you can see, 54 of the age, and down you can see the creatinine level. In the patient that has only obesity-related glomerulopathy, the creatinine level was lower as compared with the patients with other lesion alone. And as expected, when you look at the baseline serum albumin at the moment of kidney biopsy, the serum albumin was lower in the patients that have other lesions alone. What were the results? 12% of the patients, of the 239 patients, had obesity-related glomerulopathy alone. 18% of these patients have both obesity-related glomerulopathy and other renal diseases, and 69% of the patients had, in the kidney biopsy, only other renal diseases. Here you have an example of kidney biopsies of the patients. In the upper part, for example, in the A, you have, as you can see here, glomerulomegaly and ileal sclerosis. In the upper part, in the middle panel, as you can see here, there is another ileal glomerulosclerosis. In the E, you can see clearly effacement of the food processes. And in the D, you have a post-infection disease and not with glomerulomegaly. And in the F, you have a patient that has obesity but has a crescent associated to ANCA vasculitis, and as you can see here. So what about the consensus? What classification we propose? We propose OBCKD type 1, that is the patient with obesity and kidney functional alterations, potentially reversible, with hyperfiltration with or without albuminuria, in the absence of kidney biopsy, the patient that has this in the blood and urine testing or urine testing, but with the absence of kidney biopsy. We will classify obesity, chronic kidney disease type 2 for patients with obesity and kidney structural alterations related to obesity. So, obesity-related glomerulopathy, podocytopathy, glomerular hypertrophy, matrix mesenchymal expansion, or focal and segmental glomerulosclerosis, tubular interstitial fibrosis, and tubular atrophy. Obesity, OBCKD type 3, obesity and other kidney disease. For example, the patient that once biopsied, they have diabetic nephropathy, nephrangioschlerosis, and primary or secondary glomerulopathy, such AGA nephropathy, or patient diagnosed without biopsies. for genetic tests of a genetic disease, such as an Alport syndrome. Obesity, chronic kidney disease type 4, obesity in dialysis patient, a patient that is in dialysis program and has obesity, and obesity, chronic kidney disease type 5, obesity in patients with kidney transplantation. This is really important because when you classify, the patient will benefit of a personalized treatment. Let's go for obesity and kidney structural alteration. Depending the lesion that you found in the kidney biopsy, the prognosis in terms of chronic kidney disease progression will have a better or a worse prognosis. So if the patient has a glomerulomegaly, mesangial expansion, or nodular sclerosis, the prognosis will be mild. If the patient has a segmental glomerulosclerosis, the prognosis will be moderate, severe and severe in case of proteinuria, of important proteinuria. And if the patient has tubular atrophy or interstitial fibrosis, it will also be moderate, severe, depending on the extension. And important to note that the vascular lesions, as named as arteriosclerosis or arterial fibrointimal thickening, also will have a worse prognosis, as you can see here. So these are examples of obesity, chronic kidney disease type 2. In the upper part, you can see on the left panel glomerular hypertrophy. In the right panel, matrix mesangial expansion. Podocytopathy in the middle panel. Here you can see food process effacement. Focal and segmental glomerulosclerosis periliar, as you can see here in this slide. Tubular interstitial fibrosis, and in the last one, tubular atrophy. Let's go for 4 clinical cases that will illustrate. Case 1 and case 2, 50 years old male, case 1, and case 2 the same age. In the first case, body mass index 45, urinary to albumin creatinine ratio 365, creatinine 2.5, no hematuria in this patient. A kidney biopsy was performed and they found glomerulosclerosis, glomerulomegaly, mesangial expansion, and focal and segmental glomerulosclerosis. Obesity, chronic kidney disease type 2. The other phase, body mass index 45, Alport disease, a patient diagnosis with genetic test, hemodialysis, and currently in the kidney transplant waiting list. Creatinine and urinary to albumin creatinine ratio not applied because the patient is under dialysis program. Hematuria was present at the diagnosis, and kidney biopsy was not performed because the diagnosis was done by the genetic testing. Obesity, chronic kidney disease, in this case, 2 types, type 3 because the patient has Alport syndrome, and type 4 because the patient is under dialysis program. Personalized treatment for the first patient with type 2, weight loss, chronic kidney disease, targets, renin-angiotensin system blockade and SGLT2 inhibitors, and cardiovascular risk. We have to deal with the cardiovascular risk. In the other side, the other patient type 3 and 4, personalized treatment, we need that the patient weight loss, because if not, the patient will not be included in the waiting list, because there are some contraindications when the patient has a really important obesity. Cardiovascular risk treatment and genetic counseling. Is someone else in the family with obesity? Are you planning to have family? This will be with a geneticist. We will deal also with that. Another case 4, case 5, 60 years old male, both of them, body mass index 50, urinary to albumin creatinine ratio 365, hematuria present, kidney biopsy, AGA, nephropathy. Obesity, chronic kidney disease, type 3. Let's go for the other case, body mass index 50, creatinine 1.5, urinary to albumin creatinine ratio 306, kidney transplant recipient, albuminuria absent, and kidney biopsy no performance, obesity, chronic kidney disease, type 5. For the type 3, what we will do? Well, weight loss, chronic kidney disease, targets, cardiovascular risk, and personalized IgA nephropathy treatment, sparing steroids when possible. For the obesity, chronic kidney disease, type 5, weight loss, chronic kidney disease targets, chronic cardiovascular risk, and immunosuppressive treatment with sparing steroid regime when possible. So, as a conclusion, this already was presented in the Nephron Power. We thank Kenar Javeri for that. Now we have a new project in Spain that is expanded to Latin America, named Project Obesity, obesity in patients with chronic kidney disease in Spain. So we are opening the door of our clinics of chronic kidney disease and assessing how many patients, the prevalence of obesity, how many patients have now obesity in Spain. Here are the centers in Spain that are participating. 2,000 patients are being included in the study. We have already collected all the data, and as we speak, we are analyzing now this data, and we'll know the impact of obesity in our patients with chronic kidney disease in Spain. Take-home message. Is essential to understand the prevalence of chronic kidney disease, obesity in Spain and Latin America. We highly recommend to classify chronic kidney disease and obesity. What is not diagnosed or classified will be never treated, and this consensus that we propose is a key tool for personalizing treatments in patients with obesity and chronic kidney disease. And here I show you two pictures. One of the pictures is on the left side with my friend Jorge Rico, that is the past president of the Latin American Society of Nephrology, and he was the one that proposed to classify the patients with obesity and chronic kidney disease. And I think that we reach a really nice consensus of classifications. And in the right side, you can see the people that work our nephrology research department. Thank you very much.
Thank you all for joining the first EDNSG webinar. We also invite you to attend the next EDNSG annual meeting held in Malta next year, May 2026. Stay tuned for upcoming EDNSG webinar. Thank you.